Hi, my name's Jo, and thanks for coming to my website to have a look at the presentation that I did for the International Federation of Manual and Musculoskeletal Physical Therapists, IFOMPT in short, this year at their 50th anniversary birthday in Basel in Switzerland. And yes, they are now called the International Federation of Manual and Musculoskeletal Physical Therapists. So this is just a short synopsis of the presentation that I did within one of the research disciplines. And firstly, again, I would just like to thank the organisers for working so hard over the last 5-6 days for the Congress, but also to thank the Scientific Board for giving me the opportunity to present my research at IFOMPT this year. So the aim of my presentation at IFOMPT was to try to start a new narrative regarding using hands-on in manual therapy. And as the title hints to, it's about using hands-on in MSK, musculoskeletal healthcare, as a valid and reliable measurement instrument to inform patient care and the scientific practice. Now, what we got to remember is for over 75 years, research has been conducted on manual therapist hands, and most of the research says that it's a clinically unacceptable measurement instrument to be used in MSK healthcare. However, as you will see by continuing to watch the rest of this presentation, is that the research is actually flawed, and that's what the research that has said for 75 years, that manual therapists using their hands is a clinically unacceptable and an unreliable measurement instrument in MSK healthcare, is actually flawed, which I'll come to a little bit. So my name is Dr. Jo Abbott. I'm a clinical biomechanist and scientific researcher from the UK. My pronouns are she, her. I have dyslexia and ADHD. And the reasons why I tell you this is because representation matters. Thank you to my peers, Jason and Kerry. And it will become very clear quickly that I have ADHD, because when I get excited about topics, which particularly research, I find it extremely hard to stay on topic. So I'm going to try to keep this presentation succinct, but please do remember, if you have any questions or queries, or you'd like to get online and have a chat with me, let's do it, because we need to start to change the narrative and change the paradigm behind the flawed research that said that the hands are an unreliable measurement instrument to be used and are clinically unacceptable, because that's not true. So how did I end up researching a hands-on approach to manual therapy? It's a really long story and not one I want to focus on in this presentation, but in a nutshell, I wanted to use the hands-on approach of manual therapists to screen for biomechanical impairments in a specific population for my PhD. So that's point one on the roadmap you see in front of you. So the measurement instrument for my PhD would become the hands-on skills of these manual therapists. Point three is there are particular standards, and these standards are that in scientific research that all measurement instruments must meet a gold standard level. Now, that then took me to a systematic literature review. So to explore the literature to see, okay, so if I'm going to use these manual therapists in my PhD to tell me yes or no to an impairment within a specific population that has or is at risk of MSK ill health, then their hands are going to be used as this measurement instrument. Are their hands valid and reliable? So to do that, I conducted a systematic literature review of the evidence-based research. And that research has been conducted for over 75 years, and we have over 8,000 papers that have done what's called an intertester or intratester reliability study. There are lots of other terms that are used for that, but the terms I will use today and in this presentation is inter and intratester reliability. 75 years, 8,000 papers, and the majority of these papers state that hands-on is clinically unacceptable. So if we review what's happening within MSK healthcare, the industry continues to use a clinically unacceptable measurement instrument in MSK healthcare. It continues to be used. So that needs further questioning. So if we were to, the evidence-based research quite clearly states, the majority states, as a clinically unacceptable, unreliable measurement instrument and should not therefore be used in healthcare. However, when we go to the doctors, if we have a hospital appointment, very often the hands are being used by other practitioners to quantify or qualify an evaluation of why we're there. And practitioners of manual therapy disagree strongly with the evidence-based research. And we also have to question, so why also does the CDC and the European guidelines continue to recommend manual therapy as the first-line treatment for MSK healthcare? So why are the evidence-based researchers saying that hands-on is clinically unacceptable, and you have those working with their hands that are saying actually it's clinically acceptable and it works? Well, after 9 years of research, maybe both are right. Maybe both the researchers and the practitioners, maybe they're both right. Let me explain a little bit further. It's the evidence-based research that explores hands-on in musculoskeletal practice that's flawed. So the first flaw in the evidence-based research looking at hands-on as a valid and reliable measurement instrument in MSK healthcare is a thing called replication crisis. And it's a term used to describe research that cannot be replicated and therefore suggests that the original findings are not credible. Because if you can't replicate it to test the hypothesis, then how can you test the same study again? See, these are the variables, and a confounding variable means something, a confounder means that something that nobody's ever identified before. I have no answer for that. But when we think about manual therapists, if you were to go see your physiotherapist, maybe they've got pain, maybe they're tired, maybe they've had a bad day and they're a bit stressed. So these are just life experiences. And in all testers, so anyone who's placing their hands on to collect data from that other person's body. So in robotics and prosthesis, they call it active touch. Passive touch is being touched. Active touch is the person doing the touching. So if every person that's doing active touch has all these variables in them, then of course we're going to find it very, very hard to replicate the studies. So let's take, for example, here pain that's just been highlighted. So if the person who's doing the active touch has pain, it will throw out their reliability on identifying things in your body or having collecting data from your body. Unless they're controlling their pain and unless they're aware of their pain and they have modified their environment to ensure that their pain is not a distraction to them. And remember, this is all new to manual therapists as well. So this isn't about waggling fingers at anyone. This is new research. So, just to bear that in mind. There's also this thing called saturation of mechanoreceptors. So if as the person doing the active touch, i.e. if you're the physiotherapist, the chiropractor, the doctor, the phlebotomist, there's a point of time where when you're touching somebody's body that your mechanoreceptors are saturated. And that means you're not going to collect any data from that person's body. What you need to do after about 20 seconds of having your hands on someone's body is take your hands off, give them a shake and place them back on again so you can reset the mechanoreceptors back to collecting data. And this is something you see very, very common in new students of manual therapy is their hands are on for a really, really long time. And the mechanoreceptors get completely saturated. So mechanoreceptors are these little data points just under our skin, in our hands and in the palm of our hands and our fingertips, all over the hands. So if you can imagine if those mechanoreceptors consistently got information if we put on gloves, then we would probably not be able to do much with the rest of our day if we were constantly getting feedback from our hands through wearing gloves. So there is a point where the mechanoreceptors in the hands have to go to sleep because they've done as much data collection as they can. So I recommend with anyone doing hands-on in manual therapy, whether you're a sports massage therapist or an acupuncturist to a phlebotomist, hands on, give it 20 seconds. If you can't find what you're looking for, hands off, give them a shake, and then place your hands back on after you've given your hands a good shake out. And then there's also mindset. So this is a really big topic, cognitive biases and Kruger-Dunning effect, and there's lots of these things, and that's for another day, another conversation. So there are lots of things that will determine this replication crisis, and that's why intertester and intra-tester reliability studies are you can't replicate them because of all those variables in every tester. And if you didn't consider all those variables, then that's where you get just the inconsistent data points in your research outcomes. What we do know, though, is if we continue to do intertester, intra-tester reliability studies without considering all of those confounders in each individual tester and controlling for them, over the next 10 years, we're going to get another 250 studies that are going to be published telling us to get hands off because they're clinically unacceptable and unreliable, which is flawed. That is a false statement. It was true at the time to the research, but if we look at how the research has been conducted, there's quite a few flaws, and the best is yet to come. So flaw number 2 is this sampling bias. When we look at the 8,000, just under 8,000 papers that are used for the systematic review, only 4 papers considered other practitioners within MSK healthcare, and that was 1 surgeon, 2 phlebotomists, and a nurse intubating a patient and the movement of the hyoid bones. And what we've got to remember is there are more people that are using a hands-on approach in MSK healthcare that also need to have some studies conducted on them to see how valid and reliable their hands are. Flaw 3 is a thing called reverse bias, and that's where we continue to use the hands-on approach as a measurement instrument when the evidence-based research says it's unreliable. So if the evidence-based research says when we're using the hands to identify anatomy or pathology of some kind, why does research continue to use it? So what we see here is a picture of 3D motion capture markers being placed on a person's body. And to do that, the person placing the markers would need to use their hands and palpate osteological landmarks, so bony landmarks, and then they would place those markers on them. Now, the outcome of these 3D motion capture studies, because they're 3D motion capture, and 3D motion capture is a gold standard measurement instrument, often used in sports sciences, that the study would, with the outcome of the study, run in, jump in, whatever, will be identified as a gold standard test because it's used 3D motion capture. But what we've forgotten is the hands were used to place markers on the body for that study to be conducted. So right from the get-go, if we're saying that the hands are unreliable and clinically unacceptable and shouldn't be used, then right from the get-go, most of the 3D motion capture studies that have used somebody's hands to identify osteological landmarks over the last 75 years, of which 3D motion capture has not been around for that whole time, then can't we also say that any 3D motion capture studies are also flawed if the measurement instrument, being somebody's hands, identified the osteological landmarks that the markers were put on, and it's the marker data set that we analyze for a 3D motion capture study. Just a thought, just a thought. And of the 8,000 intertester and inch-tester studies, 99% of the researchers did exactly this, reverse bias. They used their hands-on skills to either select patients or apply the intervention like we see here with 3D motion capture. So that's reverse bias, flaw number 3. Okay, this is the biggest flaw of all. And if I was asked for a 10-second elevator pitch on why 75 years of research on hands-on is flawed, it would be this one. Because validity research, validity study must precede reliability studies. And for 75 years of these studies, nobody has considered validity. And why is this important? So you see here a picture of a thermometer. If I say this is a thermometer and it will measure temperature, I need to produce a validity study that demonstrates the thermometer does indeed measure temperature correctly and not, for example, distance. If and only if the thermometer succeeds its validity testing and does indeed measure temperature and not distance, then and only then do I begin to conduct research on the thermometer's reliability. So the hands-on practice of manual therapists or active touch needs to have a validity study before it has reliability. And this is the biggest flaw of all the research that has divided disciplines worldwide with regards to the hands-on, hands-off debate. Since 2006, there has been the COSMIN, which is the Consensus-Based Standards for the Selection of Health Measurement Instruments to support the evaluation of measurement instrument properties in medicine. So COSMIN have provided us with with guidelines to support and checklists to support that if we're proposing to use a measurement instrument in our practice or in research, that it does indeed have a validity study. And as you can see by this slide here in front of you, flaw 5 is what's known as a prevailing bias. So since 2006, we've had standards or criterias or to scrutinize hands-on as a measurement instrument to be used diagnostically in MSK healthcare. Yet, intertester and intra-tester reliability studies have continued, and nobody has considered applying the validity study first. And that's known as a prevailing bias. We have a set of instructions to support the validity testing. Nobody's looked at validity in hands-on and has continued conducting reliability studies. And you can quite clearly see in this table here, content validity comes first, followed by internal structure, followed by remaining measurement properties. And you can see box 6, so it's the 6th step in looking at hands-on as a valid and reliable measurement instrument to be used in MSK healthcare. So to close on this presentation, if we need to change this narrative in with regards to hands-on in manual therapy. And the beauty of failing is the opportunity, being given the opportunity to grow. We cannot assume we can all do this though. When we cannot assume that we can all do the validity and reliability to a gold standard. But with this new knowledge, it does show promise that when testers learn how to use all their active touch measurement theories, and they can identify all their confounding variables and reduce those measurement errors, then their HODA can resemble a gold standard level measurement instrument in MSK healthcare. But I think one of the main take-home messages, if we dare to move on from this, which I hope we all do, and we will start new conversations and As I've said a few times in this presentation, please contact me if you want me to do a presentation to your team or answer some Q&As. Not a problem. We can Zoom or phone call, not a problem with that. But the most important thing is what manual therapists or anyone in MSK healthcare do when they're applying their hands on a body and they're collecting data is when we look at the validity and the reliability and we do the design for it to be used as a measurement instrument, what you are doing with your hands is called HODA A, and that is you apply hands-on for data acquisition and analysis. So the hands are on the body, there's this acquiring of data, and then there's this analysis of data, which is another whole presentation in itself. So please contact me and let's hope that the new conversations begin. Thanks for listening. Thanks for watching. Speak soon.